Welcome to the OrthoPAC podcast with your hosts Sam Dyer, Chuck Dowell, and Miles Gilbreth. Please join us as we attempt to fill in the gaps between education, current events, and real-world practice. Listeners, welcome back today with Chuck Dowell and myself, but we're discussing non-orthopedic causes of pain that present in orthopedic clinics. So moving on down the list, what about systemic diseases? And the first thing that comes to my mind when we're talking about that is rheumatoid arthritis. We had rheumatologists in our practice for several years, and there are a lot of rheumatologic conditions that show up with musculoskeletal complaints. Psoriasis, ankylosing spondylitis, lupus. I mean, there are a lot of different things that can cause it. What are your thoughts on that, Chuck? When we had a rheumatologist in the house and I would have these kind of vague back pains, extremity pains, whatever, I would ask them what labs would they draw and what kind of workup would they do. So it was very nice to have a rheumatologist to tell you kind of how they would approach it without doing the expensive labs that they like to do, the genetic markers and all that. So I had a fairly set routine, a rheumatoid panel that I like to do. But what are your thoughts on that? What kinds of patients have you had show up with a systemic disease that wasn't really an orthopedic condition?
Yeah. Again, the big ones are these polymyalgia, complaints, fibromyalgia, rheumatoid, psoriatic arthritis, osteoarthritis. And then you can kind of, go into the more myositis type, muscular complaints. And I think you see a lot of that, especially if somebody comes in complaining of multiple joint pain with no fall, no onset, with maybe swelling within multiple joints. You have to think, is this more of a systemic disorder? Do I need to get, as you said, this rheumatological workup? We had a rheumatologist at our practice as well that I used to send a lot of these patients to, and he unfortunately retired. And since then, it's been hard to find a rheumatologist to follow up with. So sometimes we have to be the initial evaluator of these and see if they do have, ESR, uh, high CRP, high CBC, maybe even RA factors as an initial workup, and then have them follow up with their primary regarding it. Even Lyme disease, if you live in the part of the country where Lyme disease is a common complaint, this will often come in complaining of more joint pain or polymyalgia or polyarthralgia. And so definitely something you have to think about, especially during the season.
Yeah, and the rheumatologic stuff, it doesn't necessarily have to be rheumatoid arthritis. So you get a little screening panel and it comes back. Have you ever seen somebody that's seen a rheumatologist that had non-specific polymyalgias or polyarthropathies or whatever that they couldn't really find an exact reason why, but they presented like classic symptoms and so they're treated as such. So it's not always cut and dry there either. What about thyroid disease? Have you had any experience with people that have had, say, hypothyroidism that have chronic pain? And I think one of the things about hypothyroidism is chronic fatigue and tiredness or lethargy and that kind of thing. So, have you had anybody like that that you were able to say, well, I think your stuff is related to thyroid? It kind of, from an orthopedic standpoint, becomes a diagnosis of exclusion, I think. But what are your thoughts, Chuck?
When somebody comes in and they're complaining of more of this gradual onset of multi-joint pain, I always have a screening questions that I ask them regarding comorbidities, and thyroid disease, Hashimoto's disease is definitely part of that because we know that that can often cause joint pain with weight loss, and or even hypothyroidism causing joint pain. And so that's always part of my screening questions when I can't really seem to have the symptoms and or the complaints fit the examination and or the x-ray findings. If the x-rays are normal, don't show any significant osteoarthritis, yet they have joint swelling and joint pain, you have to think of these underlying diseases. And obviously, a crystalline arthropathy, pseudo gout, and gout always comes into play. And I don't know if you had that on your list to discuss, but common complaint that we see a lot of patients coming in with swollen red, painful joints, and not only the first MTP, oftentimes ankles, knees will come in with these similar complaints. And they may not have any underlying history. They may not have that classic, I went out and had a seafood dinner or, drank a bunch of hoppy beers or red wines or any of those common triggers that you see. So always important to keep that in the back of your mind when somebody comes in with these complaints.
Absolutely. I'm glad you picked up gout. I meant to mention that, but I'm glad you did. Gout, pseudo gout. And I can't tell you how many times I've seen patients with chondrocalcinosis or pseudo gout, and you see the little thing on the x ray, and they get sent for an MRI, and it's not really like an injury or something. It's just pain that started and an effusion. They can't figure out why. Try a cortisone injection for that patient. If you think that they might have a tear, sure, get the MRI and whatnot, but you don't need to get an MRI to diagnose chondrocalcinosis. You can typically see it on the x-ray, and you give them a cortisone injection, it works great. And that's my experience with that. And the reason I bring it up is because I've seen it many times. Let's see. I have one last kind of general category, medications that can cause orthopedic pain. And there are a lot of medications that have side effects. I'll start with one. I'm sure Chuck will give you a second. I haven't provided Chuck with a list of this. That tells you how smart this guy is because he can pop all this off the top of his head. I have to write mine down. So, but meds that can cause orthopedic pain, and the big one that comes to mind right off the bat that I've seen a bunch of times that people ask me about are statin drugs. There are studies that show that statins do, and there are people that get this, that statins do cause musculoskeletal pain. And the pain comes in a variety of flavors. It could be back pain, it could be joint pains, it could be anything. The thing that's different that I've experienced is the length of time to onset of pain and how long it takes it to go away once they stop the meds or if they start a different kind. So that's the commonality that I've seen. And I've got a list of several others, but I've given Chuck a chance to think about it. So what do you think, Chuck? What kind of meds have you had experience with patients that have had musculoskeletal complaints?
Yeah, that's a great one. Again, that's part of my screening questions for sure. Statin medications, as you said, I think are definitely part of it. Probably the most common ones that I can think of, fluoroquinolones, obviously are a concern, especially if somebody's coming in complaining of tendon type pain, acute onset of Achilles tendonitis, patella tendonitis, quad tendonitis. I always ask about recent antibiotic use or fluoroquinolones, or if somebody comes in with Achilles tendon rupture, I ask about that question just as a screening parameter. Bisphosphonates is a huge one. Somebody that has osteopenia, osteoporosis, and is on bisphosphonates, we know that that can sometimes predispose them to fractures because of the, osteoblast, osteoclast turnover. And so I'll always ask that question, especially if their complaints are more weight bearing, more bony type complaints, and I'm worried that they could have a stress or fatigue or insufficiency fracture within one of their weight bearing joints, the hip, the pelvis, the sacrum. I'll always ask about history of osteopenia, osteoporosis, and if they're on bisphosphonates. And then I've had two patients on Ritalin come in complaining of joint pain that it ended up being associated with that. So those are the only ones I could think of off the top of my head, but those are the common ones I feel like I've seen in the past.
Great. That's great answers. I made a little list ahead of time, so I'm cheating here. But another one that I wouldn't normally think of, but since I wrote the list, I'm thinking, yeah, why didn't you think of that? Would be retinoids. People that are taking the retinoids for acne, the young folks. Keep that in mind. That is a possibility. Antibiotics, like Chuck said, anti-diabetic medications, some of the newer classes. Pregabalin, I'm not sure how that could result in pain, but that apparently is a common one. And then opioids. And I thought, well, how in the world could opioids increase musculoskeletal pain? And the answer is you build up a tolerance. So our chronic pain patients that have a tolerance to opioids, when they have a decrease in that medication, their pain response increases. So keep that in mind. All of this stuff, you got to think outside the box. It doesn't fit in your normal algorithm of how you're diagnosing and treating these conditions or back pain, neck pain, extremity pain, whatever. So make sure that you consider what are the non-orthopedic causes of pain that present in your clinics. So good discussion. Good discussion. Chuck, what else? What have we missed? What else do we need to cover?
No, as you said, I think that's great. I think my thought process and when I have students working with me, the thing I was trying to get across is exactly what you said. If things don't add up, sit down and try to think outside the box. And I'm not shy of sitting in the room with the patient in silence for 2 or 3 minutes while I'm just trying to process things in my head and think about things in my head and decide if this is fitting a normal picture. And I'm also not shy about asking for help. I think that's a big thing. We have colleagues with a lot of more of experience, and I'll often call and or ask if I'm working with another PA or if I have a doc that's easy to get a hold of. Technology these days is great. We have the ability to text people, so I think that's definitely something that don't be shy to ask for help. You don't have to keep the patient in clinic. You can discharge them from clinic, but ask a colleague and say, "Hey, I had this patient. What are your thought processes on this?" And oftentimes getting that outside the box or outside the tunnel vision perspective will key something in. And as you said, it's often something you knew, but you just weren't thinking about in that moment or that time. The other thing I thought about when we had this, talk or idea was still orthopedic complaints, but is there a pathologic component to the patient's fracture pattern? I think is important to think about. I had a lady come in who said she picked up her purse and had a humerus fracture. And in my mind, that doesn't make sense. You don't just break your humerus by picking your purse up, despite how heavy that purse may be. And so I immediately started to think, well, what else could be causing this? And I started to ask those questions. Do you have a history of osteoporosis, osteopenia? Do you have any comorbidities or thyroid dysfunctions? Have you recently taken any medications? Are you on any bisphosphonates? All of these things that can cause these low level fractures to occur. And after looking at the x-rays, I realized there was a lytic pattern to the x-rays and ended up sending her to the orthopedic oncologist. And she had that was her presentation, unfortunately, for breast cancer. And so, again, remember that there are certain types of cancers that will metastasize to the bone. And if somebody comes in with a fracture complaint and or has a fracture, and it's a very low level injury to cause it, you have to think of what other causes could have caused it.
Yeah, I think the acronym that I remember for that is lead kettle. The sign for lead, PB, prostate, breast, what's the kettle? Kidneys, esophageal, thoracic, thymus, and lung, if I remember right. See, even I, an old guy, can remember things sometimes. So there you go. I would add a little bit. Common things occur commonly, and you hear that over and over. Well, sometimes common things don't occur commonly, or sometimes uncommon things occur. And you have to think outside the box, like Chuck said. I look at it like this. There are a lot of things I know. If I've seen 100, 200 wrist fractures, I kind of know what a wrist fracture is. If I've seen knee arthritis 100 times, I kind of know what that is. You'll get to a point in your diagnostic capabilities where most things when you just have a couple of lines of history before you even go in the room. I had one of our surgeons tell me that early on in the practice, and I thought, well, that's kind of being very cavalier and facetious, but it's true. You see something over and over and over and over, and you kind of know what it is. So when something oddball shows up that's just not quite right, don't just blow that off. It's important that you think, wait a second, what could be causing this? And there are other things that can cause musculoskeletal complaints rather than trauma, rather than arthritis, rather than degenerative changes. So just keep it in mind. We wanted to do this to make sure that you put on your thinking cap sometimes and make sure you understand that there are other things. So I think it's a great discussion. And Chuck, I appreciate you coming on today, sharing some of your experiences. And I believe that's all we got. So until next time, thanks a lot, listeners, and we'll talk to you soon. Listeners, please follow up next week. Hope you can join us at one of our upcoming CME meetings. We have our Ortho in the West annual conference, March 28th through March 30th. Look on paos.org for details.